Welcome to Unit 4, where we will review schizophrenia and other psychotic disorders in childhood. And the verse guiding this lesson is, "So do not fear, for I am with you. Do not be dismayed, for I am your God. I will strengthen you and help you. I will uphold you with my righteous right hand." That's from Isaiah chapter 41, verse 10. Psychosis can be very scary for children and for their families. And in fact, the term catatonia, that can often be a subtype of schizophrenia, is actually the state of extreme fear. So spiritual care is certainly indicated in helping to guide our families during these difficult challenges. Psychotic illnesses, including schizophrenia, are actually a group of heterogeneous conditions with multifactorial causes, and these do include both environmental as well as genetic factors. And prenatal insults can certainly be a contributing factor, as well as genetic factors, and then later environmental factors. In general, there are considered to be 3 categories of symptom clusters. And certainly we have the positive symptoms, which those are things that a patient has that they should not have, such as hallucinations or delusions. And negative symptoms, which are things that they do not have that they should have, which include things like apathy or caring about things, autism, or inability to interact, as well cognitive symptoms or trouble with the thought process. It is rare for schizophrenia to have an onset in childhood, and a very early onset of psychosis, or that occurring before the age of 13, is very rare. It does happen in males more frequently than females and has a very poor prognosis. Early onset psychosis is similar, though that is considered an onset before the age of 16. Schizophrenia generally has a later onset, later adolescence, and does have a better prognosis. And it does occur more frequently in males than females as well. Early identification and treatment of psychosis is very important, and research showing more and more the association with improved patient outcomes when there is earlier and adequate treatment for psychosis. So things to be on the lookout for include psychosocial functioning. You'll see a decrease in their ability to function and interact socially, and may become very socially withdrawn and performing worse at school or work, and then developing increased distress and agitation without any triggers causing it, any identified external triggers. And raising awareness is key for individuals working with youth about the importance for this early intervention. So we really need to raise awareness. Of course, the use of psychotropic medication, antipsychotics with children and adolescents is certainly one that gives many providers pause. However, there's a lot of research showing that this early intervention is very helpful, and pharmacologic treatment is often necessary. Now, of course, psychosocial interventions are important as well, and promoting recovery. It will incorporate a focus on education, employment, and care coordination in all settings and with all caregivers. And so all antipsychotic drugs do interact with a number of neurotransmitter systems, And the first generation antipsychotics typically block D2 receptors, but can block other dopamine receptors and are effective at reducing positive symptoms such as delusions, hallucinations, and formal thought disorders. And they can also help with agitation and aggressiveness. They are, however, associated with elevated prolactin levels and extrapyramidal side effects, which can include tremor, dystonic reactions, and tardive dyskinesia. And there is a rare side effect of neuroleptic malignant syndrome, NMS, which we have to watch out for with any antipsychotic. And hallmark signs for that are going to be that increased fever and muscle rigidity and increasing blood pressure. Now, second generation antipsychotics do vary a bit in their receptor affinity because they target serotonergic or 5-HT2A receptors as well as D2 receptors. They can also target other receptors, including mu receptors and D4 and D5. It was initially thought that the second generation antipsychotics would be effective in reducing negative symptoms, and they are to some degree, but certainly not completely. And extrapyramidal symptoms can exacerbate negative symptoms as well. Though second generation antipsychotics have fewer risks for EPS, though this at times can give a false impression that they don't cause side effects, but they actually have their own significant side effect profile, and weight gain, dyslipidemia, and ultimately type 2 diabetes can be some significant risks with these medications. And this figure is showing the effects of the antipsychotic medication according to the various dopamine pathways. And so here are the various dopamine pathways: the nigrostriatal, mesolimbic, mesocortical, and the tegmental or tuberoinfundibular. And this slide is showing the associated function for the antipsychotic medication that is targeting each pathway, and as well the effect of dopamine blockade in that pathway. And as we recall from our psychopharmacology class, antipsychotic effect is achieved when at least 60%, 60 to 75% of the D2 receptors have been blocked. And extrapyramidal symptoms can occur then when 80% or more of the D2 receptors have been blocked. So we want to be careful about unnecessarily increasing doses or using two antipsychotics that could result in more side effects rather than more symptom improvement. And here we have the World Health Organization's essential medication list for antipsychotic medications. However, this is the 2015 version. The most current one posted to date is from 2019, and that one only includes thorazine or chlorpromazine and haloperidol or Haldol. So those are the only two on the list currently. And for depression medication or mood disorders, actually it has listed flufenazine or Prozac is the only medication listed. And what that means as far as being on the WHO essential medications list is just that these are medications that must be made available for prescription at a price that the community can afford. Medications that are not on this list are less likely to be available at all in low and middle income countries. And these are some additional antipsychotics listed on the 2015 edition as well. This is the edition, the general edition. The one, again, specific for children, only includes Haldol and Thorazine at present. And this graphic is a very nice resource showing both the dosage range as well as the propensity for the drug to cause EPS, sedation, or waking. Long-acting injectable antipsychotics have actually been around since the 1960s, with a couple of first-generation antipsychotics available in this form, such as Haldol decanoate or Prolixin decanoate. And they have not been widely used for a variety of reasons and are still underutilized today. Traditionally, the main reason for using long-acting injectables was for poor adherence to medication. Non-adherence to medication certainly is one of the most frequent modifiable risk factors for recurrences of schizophrenia. However, there are other reasons for utilizing these medications, and as they are available in a multitude of formulations, improved delivery system and therapeutic levels is certainly another reason for considering them. Now, certainly these are indicated at different stages of treatment and certainly not initially. So initially, we really want to identify what medication a patient is going to respond to and what the effective dose is. But certainly, some individuals have concern about a patient's acceptance of a long-acting injectable, and so that may be a hesitation as well. There really is not any evidence that there are increased side effects with their use, and in general, though, they should not be used for short-term therapy, and so probably are not utilized as frequently with our younger population. And they are recommended, though, for any patient requiring long-term treatment. They are recommended for patients with schizophrenia, and certainly need to have a very careful informed consent process, both with the guardian as well as with the patient, and reviewing all of the risks and benefits of their use is very important. And these medications are not indicated for the treatment of bipolar disorder. Long-acting injectables are not approved for use with children or adolescents either for the treatment of schizophrenia. However, occasionally they are used off-label for treatment of older adolescents who have adult body weights. And here's a review of some of the long-acting injectable antipsychotics, and showing some of both the first and the second generation medications, and do have a list of some time frames that the medications are available in, and some considerations such as the need for concurrent antiparkinson medication along with the first generation. So may need to have a prescription for Cogentin prophylactically to go along with that. And dystonic reactions can occur more often with the first generation antipsychotics, and it's not uncommon to see them in emergency room settings, either as a reason for an individual seeking emergency room treatment or in the response to an emergency treatment order for agitation with administration of an intramuscular antipsychotic. And it is often seen in younger patients and can occur not only from antipsychotics, but from an antiemetic as well. And there are several different ways that it might manifest, such as an oculogyric crisis, the torticollis, macroglossia, buccolingual crisis, or a laryngospasm. And so obviously when a patient presents with these symptoms, the differential diagnosis would be to consider tetanus poisoning, hyperventilation, hypocalcemia, hypermagnesium, Wilson's disease, or catatonia. And just a review of some of these dystonic reactions. The oculogyric crisis is that spasm of the extraorbital muscles, which produces a deviation of the eyes turning upward and outwards. And the torticollis is where the head becomes turned to one side and can have painful muscle spasms. And opisthotonos is an uncomfortable forward extension of the neck. Macroglossia is where the tongue protrudes and feels like it's swollen, but it's not actually appeared swollen. And the buccolingual crisis can present with a grinning expression or other types of grimaces from spasm of the facial muscles. And then laryngospasm, spasm of the vocal cords that can make it temporarily difficult to speak or breathe. And this onset can be sudden and can be quite frightening. Treatment for dystonic reactions, of course, includes the anticholinergic drugs, such as benztropine or Cogentin, and that can be administered even intravenously. Or antihistamines, Benadryl is a common treatment for dystonia. And usually a patient responds pretty quickly within 5 minutes and can be totally symptom-free by 15 minutes. If not, the treatment can be repeated after 10 minutes when intravenous. And for children with dystonia, benztropine can be administered either IM or IV. And the pediatric dosing is 0.02 milligrams to kilograms with a max of 1 milligram. And then it's important to wait at least 30 minutes with children. If a child is not responding, then it would be important to consider what other causes could be going on. As mentioned earlier, neuroleptic malignant syndrome, NMS, is a rare but potentially fatal side effect for antipsychotics, and so must always be presented in the risk-benefit analysis. And so some of the hallmark symptoms of this can be autonomic instability with hyperthermia, muscular rigidity, tachycardia, confusion. And in educating families now to watch out for NMS, it can be challenging with a viral pandemic going on. And as well, children are commonly experience various viral syndromes that may present with fever. However, I still tell families just to call and report any experience of fever, just so we can assess for other symptoms, such as the autonomic instability, the muscular rigidity, confusion. Other physiological signs that go along with NMS can be an increased creatinine, phosphokinase, and leukocytes. And it is more common for NMS to occur in the first weeks of treatment or with increasing doses. And again, it can be potentially fatal and does require immediate emergency room critical care unit treatment for stabilizing the autonomic nervous system. And so stopping the medication is certainly indicated as well, along with the supportive management. And so antipsychotic medications can be very helpful to treat psychosis, and as we know, are used to treat other disorders, as many are FDA approved for the treatment as well of bipolar disorder or adjunctive treatment for depression. But there are quite a lot of side effects that go along with them. So their use really needs to be considered carefully. And so these side effects can include the extrapyramidal symptoms that we just discussed, risk for NMS, but other symptoms include sedation, weight gain, a risk for developing metabolic syndrome or other endocrine disorders, even developing diabetes. Hematological side effects can include a lowering of the white blood cells, and these medicines also lower the seizure threshold, and many have some cardiovascular side effects, such as hypotension or prolonging of the QT cardiac response on EKG, and so putting one at risk for adverse cardiac events or dysrhythmias. And of course, no one likes weight gain, but we know that weight gain can bring along with it some significant medical comorbidities. And weight gain is the most common long-term adverse effect of atypical antipsychotics. 5% will have weight gain within the first couple of months, and many will have at least a 0.5 increase in their BMI. And dyslipidemia, metabolic syndrome, diabetes, hypertension, polycystic ovary, these are some additional metabolic and endocrine reactions that can occur. And all of these take their toll as well on the emotional presentation, because it can contribute to social withdrawal or low self-esteem, and often can be the cause for treatment discontinuation, which can then lead to decompensation and recurrence of symptoms. So the prevention of metabolic syndrome is so important, and so early identification of precursors for it are important, which certainly weight gain is the most frequent. And so metabolic syndrome involves the experience of obesity, hypertriglyceridemia, low HDL, and hypertension. And it can also impact insulin secretion, and it occurs most frequently with clozapine and olanzapine, but it can occur with any of the atypical antipsychotics. And the way to prevent weight gain and metabolic syndrome involves early incorporation of some healthy habits, including diet and exercise. And the goal is to maintain a BMI under 25. And so the prescriber needs to monitor clinically the weight, waist circumference, and fasting glucose and lipids when prescribing these medications. And the type of dietary and exercise advice that should be provided includes the need for small, frequent, and slower meals with increased fluid, and reducing sugar and saturated fats, reducing processed white flour, encouraging water instead of juice and soda, and increasing fiber, fruits, and vegetables. The child really needs to exercise 30 to 60 minutes each day. Our society has become much more sedentary, and the use of electronics and video games has only reinforced that. So while you might think being active for 30 to 60 minutes each day should be typical for a child or an adolescent, in today's lifestyle here in the United States, it often is not and can be quite challenging. So this, however, is an important goal. So spending time with the child and the family, identifying what types of physical activities can be expected or that the child would like to participate in, and setting up a contingency management program with some type of reward system for completing the activities may be necessary. And again, so I can't stress enough the need for effective treatment and management for a first episode of psychosis. And that often will occur during adolescence or early adulthood. And a quarter of these patients can have a complete recovery after a first episode if it's treated appropriately. And most guidelines recommend treatment for at least 1 to 3 years. So it's not forever, but it is for a long enough period of time to prevent relapse. So we want to achieve remission, and in order to achieve and sustain remission, we have to titrate to the effective dose. And then when in a maintenance phase, we want to reduce very slowly and have frequent periods for monitoring. And so we do want to get to a minimal dose or a maintenance dose, again, because of the side effect burden of these medications. Consequences of relapse are severe, and that's why ongoing treatment is needed, even if it's preventative. And consequences of relapse can include impairment in the individual's social abilities, in their family dynamics, in their achievement of an education or ability to work. And as well, each recurring episode increases treatment resistance and can cause psychological distress. So adequate management for this first episode of psychosis is so important. And if it's not achieved, there can be some devastating consequences. Other important considerations in treatment of psychosis in children and adolescents involves the reliability of the diagnosis. Certainly, a neurological workup is imperative for the initial presentation of psychotic symptoms. It's important to identify if there is also a mood disorder going on, such as a bipolar disorder. When that is the case, then a diagnosis of schizoaffective disorder may be indicated. So it's important to really get a careful history identifying the duration of the episode, the nature of the episode, and again, identifying if there is a history of a previous occurrence. Did they have a complete recovery? Did they actually achieve remission, or did they have persistent symptoms with a partial improvement? And it's important to identify the patient and family's level of insight and treatment resistance. Has there been any problems with adherence to medications? And comorbid conditions can include other things such as substance use disorders, ADHD, anxiety. So some other conditions can occur comorbidly. And it's important to identify the age of onset, any previous episodes, and identify what kind of transitions were happening in the family system or with the child, any adverse childhood events, and what type of support do they have available, and what type of medication side effects had they had previously as well. So all of this is important in developing a treatment plan that's going to promote recovery. Overuse of antipsychotics is a problem in the US, and misuse of antipsychotics by some older adolescents can occur as well. The overuse of antipsychotics with youth has been going on in the US since the 1990s, where many of them are being prescribed off-label for behavioral management. And that's worrisome because of the adverse side effect burden. And many of these prescribers are not trained in psychiatry, so they may not be dosing or monitoring appropriately. There may be other options to manage behavior that have fewer side effects. So that's important when treating a child or adolescent for ADHD, a disruptive behavior disorder, even a severe depression that's not remitting. Perhaps rather than adding on the antipsychotic, there may be another approach, such as the utilization of Wellbutrin, and again, anxiety. So the side effect profile is significant. However, yes, these patients can have a more immediate response to an antipsychotic, which is why they are commonly used. But really, implementation of behavioral management practices and alternative medications really is a much safer approach. There are various levels of care that may need to be considered for a child and may need to consider inpatient hospitalization if the child or family is not engaged in treatment and the individual is actively psychotic. And this might even need an involuntary Baker Act or minor Baker Act. And significant risk of injury to self or others, of course, is always a criteria for inpatient unit. And when there is inadequate community or family support, or the crisis is just too severe, then may need to consider things such as supportive housing or residential treatment. There are many barriers to treatment for children and adolescents experiencing psychotic disorders. Certainly, there is a stigma associated with mental illness, and these are some of the most evident and impairing of mental disorders. And so occasionally they may be left untreated, or treatment can be discontinued in families that have treatment resistance to begin with, and then the cost of medication and the cost of monitoring and various lack of resources is certainly problematic. And there is a higher rate of alcohol and drug misuse for children and adolescents with these disorders. So it's important for mental health providers to keep close contact with these children and families using telemedicine, using telepsychiatry I have days with my children and families where I have a 0 cancellation rate. So telemedicine is certainly more effective. Many of these families have difficulty getting to appointments, with transportation being a barrier. And closer cooperation and coordination of care with the primary care provider or pediatrician is important, as well as interaction and treatment planning that includes the educators or teachers and other elders and religious figures and important people in the child's life. And so a team approach is necessary, which occurs commonly in the inpatient setting, but we need to continue this interdisciplinary treatment planning process when the child is at home as well.